Welcome back, colleagues. In today's case review, we'll examine a powerful illustration of multimodal imaging in transthyretin cardiac amyloidosis. Let's begin with the clinical presentation. Our patient is a 74-year-old man who presented with progressive exertional dyspnea, classified as New York Heart Association, NYHA Functional Class 3. His symptom burden reflected advanced functional limitation, and this was corroborated by a markedly elevated N-terminal pro-B-type natriuretic peptide, NT-proBNP, level of 2,805 picograms per milliliter. Initial laboratory investigations, including serum and urine immunofixation, were negative for monoclonal proteins, effectively excluding light chain AL amyloidosis. Let's walk through the multimodality diagnostic sequence, beginning with transthoracic echocardiography. First, long-axis 4CH and SAX views. Significant left ventricular hypertrophy, with concentric wall thickening, a granular sparkling appearance of the myocardium, a classical though non-specific finding, a dilated left atrium, consistent with chronic diastolic elevation of filling pressures, a reduced LVEF of 45%, indicating impaired systolic function in this case, and restrictive diastolic physiology on Doppler flow evaluation. On speckle tracking strain imaging, the pattern was classic. Markedly impaired longitudinal strain in the basal and mid segments, and preserved apical strain, a signature finding known as apical sparing. Next, center strain bullseye, peak systolic strain map. This pattern, when seen with concentric LV hypertrophy, is highly suggestive of amyloid infiltration. Nuclear scintigraphy, whole-body planar scan. The patient underwent 99 MTC-labeled bone scintigraphy, which demonstrated Perugini grade 3 uptake, indicating intense myocardial tracer accumulation, with uptake equal to or greater than that of bone. This pattern is diagnostic of a TTR cardiac amyloidosis, provided monoclonal protein exclusion has been confirmed, which it had been in this case. Cardiac MRI, CMR. SAX LGE. On CMR, they observed extensive late gadolinium enhancement, LGE, with near circumferential involvement. Notably, there was difficulty nulling the myocardium, which is highly characteristic of cardiac amyloidosis. Increased wall thickness and signal heterogeneity were also present. Together, these findings supported a diagnosis of infiltrative cardiomyopathy, most consistent with ATTR. Outcome and autopsy findings. Unfortunately, the patient died of progressive heart failure during follow-up. Post-mortem cross-section of the heart. Post-mortem examination confirmed. Marked biventricular hypertrophy. Histologic confirmation of amyloid transthyretin deposition throughout the myocardium. This gross pathology shows a thickened rubbery myocardium, classic for advanced ATTR cardiomyopathy. This case exemplifies the strength of multimodal imaging in cardiac amyloidosis, with alignment across echocardiographic structure and strain patterns, bone scintigraphy with Perugini grade 3 uptake, LGE-CMR features including diffuse enhancement and nulling difficulty, and pathologic correlation at autopsy. It also underscores that ATTR-CM can present with systolic dysfunction, although more often it preserves EF initially. Apical sparing and strain, paired with wall thickening, should prompt immediate amyloidosis evaluation. Key points. Granular sparkling, LVH, and enlarged LA are suggestive but nonspecific. Apical sparing and longitudinal strain is highly predictive. Perugini grade 2 or higher with absent monoclonal protein is diagnostic for ATTR. Diffuse LGE with nulling issues on CMR supports amyloid infiltration. Post-mortem correlation is rare but remains the gold standard for pathologic confirmation. Thank you for your attention. This case highlights how critical it is to recognize the imaging hallmarks of cardiac amyloidosis early and to coordinate across disciplines to arrive at a timely diagnosis. See you in the next case study.